So for those of you new to us, Autistica is the UK's autism research charity, and we exist to create breakthroughs that enable every autistic person to live a happy, healthy, long life. So we fund research and we shape policy, and we work with autistic people to understand their needs. And we also work in partnership with others to ensure that research really changes. So it's not just research for the sake of research, but research to change lives. And a big part of what we do is actually sharing the latest research and the latest evidence-based practice, which is what these webinars are all about. So tonight's webinar is going to be on autism and anorexia, so that we know autistic women are more likely to develop anorexia than non-autistic women. And so we're going to learn about lived experience of autism and anorexia and what the latest research says to help us understand how eating disorder supports can be adapted for autistic women. So our first speakers, Charli and Janina, will be sharing their research from the Autistica-funded SEDAF project. And then after them, we'll have Josefina, who will be sharing her knowledge as an autistic woman with experience of anorexia. So Charli is a PhD student at Cardiff University, and her PhD focuses on the overlap between eating disorders and autism, specifically looking at how eating disorder services can adapt to accommodate autistic individuals. And Janina is a final year PhD student at UCL, where she is supervised by Will Mandy and Lucy Serpel. Janina's PhD is also part of the SEDAF project, which is a study of eating disorders in autistic females in collaboration with researchers at Cardiff University, including Charli. I'll pass over them to now, and they'll be able to discuss their research a lot better than I have done. So over to you guys.
Thank you so much, Bethan. So I'm going to start by sharing my screen, then I'm going to pass over to Janina in a bit. So if I just share my screen with you. Okay. There we go. So hopefully you should be able to see that now.
Yeah, that looks good.
Great, thank you. So yeah, as was just introduced, I'm a final year PhD student at Cardiff University. And today my colleague Janina and I are going to be talking about just some of the research that we've carried out over the past few years as part of our PhDs. It's been looking at autism and eating disorders and the overlap between the two, but particularly thinking about anorexia nervosa in autistic women. As Bethan's already mentioned, it's a collaborative project between Cardiff University and UCL, and it's called the Study of Eating Disorders in Autistic Females, or we shorten it to SEDAF, it's a bit easier to say. And I've just included mine and also the project's Twitter handles just below on that slide, if you are interested in following our work online. So I'm just going to start with a bit of background about the two conditions that I'm going to be talking about today. I guess just thinking about them a bit side by side. So to broaden our understanding of this topic area, today Janina and I are going to be talking about our two overarching research aims. So firstly, we wanted to gain a deeper understanding of autistic women's experiences of using eating disorder services. And Janina is going to be talking more about our second aim, which was to identify the potential factors that might lead an autistic woman to develop an eating disorder such as anorexia. And she'll also be talking about our sub-aim, which was to develop a model based on our findings, which kind of depicts those autism-specific factors and how they might lead to restrictive eating difficulties. So to address our research aims, we carried out a qualitative interview study, which was made up of 3 participant groups. So this was 15 autistic women who had experience of anorexia, 12 parents of autistic women who had experienced anorexia, and 16 healthcare professionals who were working either in eating disorder services or autism services. And we recruited these participants from all over the UK. On average, the interviews lasted between 1.5 hours. And we carried these out mostly in person, but some were also carried out over the phone or over video call, kind of depending on the participant's own preference. So to analyse our data sets, the interviews that we carried out, we used a method called thematic analysis, and this helped us to develop themes. And during our analysis, we had 2 autistic advisors who both had experience of anorexia, and they commented on the theme development. But they actually contributed throughout the project, but this kind of particular step helped us to ensure that through our data analysis, we were accurately representing the autistic voice. And when we were analysing our data from our 3 participant groups, we wanted to ensure that the autistic women's voice was the dominant voice in our analysis, because after all, it is about their experiences. So how we did this was we first analysed the autistic women's data. This was followed by parents and healthcare professionals' data. And these latter 2 were kind of guided by the analysis of the autistic women's data. So as I mentioned, I'm going to be focusing on this first research aim, which was to explore autistic women's experiences of using eating disorder services. And for this research question, we had 3 overall themes, which I'm going to share with you now. So these were the misunderstanding of autism and autistic traits, one treatment does not fit all, and improving accessibility and engagement within services. So I'm going to start with our first theme here, which is misunderstanding autism and autistic traits. And this theme we kind of split into 2. Firstly was to describe the women's experiences before they had received their autism diagnosis, and secondly just to describe their experiences after they had received an autism diagnosis. Because what we found in our sample was that actually almost all of the autistic women and the autistic daughters of parents that we spoke to had been diagnosed with anorexia before they had their autism diagnosis. So actually what this meant in practice was that many of them experienced eating disorder services both with and without a diagnosis of autism. So before they had received their autism diagnosis, the women described to us how staff members within eating disorder services would often misinterpret their autistic traits as being eating disorder fueled behaviours. So I've got an example quote here from a woman who said, "When I was in hospital, I kept getting told off for walking on tiptoes and for fidgeting a lot. They thought I was doing these things to burn more calories, except I've been doing them for as long as I could remember." And once they had received their autism diagnosis, some women did describe actually that they had a better experience of eating disorder services on the whole. But actually what we found was this tended to be a minority of the women that we spoke to. And some still felt that their diagnosis wasn't taken into consideration in their treatment. And one woman even described herself as too complex a case for services to handle. And actually, unfortunately, what we heard from some healthcare professionals as well was that this was the case with some services, as they said, "I think the coexistence of autism as well as the eating disorder is something that just makes adult teams feel it's just too complicated, we just don't really want to know." So I'm going to move on to our next theme, which is one treatment does not fit all. And I guess this theme kind of thinks about the types of treatment and therapeutic styles that these women receive for their eating disorder. And 2 predominant themes around treatment that were generally felt to be the least beneficial for these women was that of cognitive behavioural therapy, or CBT, and therapy that was delivered within a group setting. So traditional CBT was thought by many of the women to be inaccessible, as it didn't really suit their natural way of thinking and processing information. And this isn't to say that CBT would be completely inappropriate for autistic people, and actually some women did find it helpful, but actually in its traditional form without any adaptations, for many of these women it was considered to be fairly inaccessible and unhelpful. And group therapy, as you can imagine, was very challenging for those who had difficulties in social situations. I've got a quote from a participant here who said, "I'm largely silent in any sort of group situation because I don't know what's expected of me. I'm worried of saying the wrong thing, or I worry about misinterpreting people." But there were some other aspects of treatment that were felt to be more accessible for many of the women. And these tended to be things like dialectical behaviour therapy, also known as DBT, and occupational therapy. And these were things that had more kind of practical elements to them. And as this participant here said, "We didn't really focus on my eating. They made me focus on emotion regulation and just mindfulness really, and social aspects. And that really helped me. And for those who aren't familiar with dialectical behaviour therapy, it involves kind of aspects of mindfulness and learning skills around emotion regulation. And this was something that some of the women we spoke to did find particularly helpful. So our last theme is improving accessibility and engagement within services. And this theme largely speaks to two areas of service adaptation that were felt to be beneficial for the autistic women. So firstly was thinking about communication between the autistic women and the staff members that they encountered during their eating disorder service experiences. And particularly staff members who were able to adapt their own communication styles to meet the preferences of the autistic women were praised the most highly. So this woman here said, "She understood how best to communicate with me. So she gave me written summaries after my appointments. She gave me written information and we used goal setting to help plan my care." And the second area of service adaptation was more to do with physical adaptations to the environment. So, and this could include, at least just being flexible to allow for adjustments, as well as kind of making these adjustments permanent. And this could be as simple as kind of turning off fluorescent lights kind of for therapeutic sessions, or just being mindful of any distracting noises, such as a radio. And I've got an example here from a healthcare professional who said, noise is something that has got to 2 patients and they found that really difficult. So we made allowances in terms of music therapy taking place as far away from her as possible. So that's just a quick overview of our study on the service experiences, eating disorder service experiences of autistic women. And this paper is available online, and I'm more than happy to circulate it. I think a link's going to be sent around later as well, if you are interested in reading a bit more about this study. But before I hand over to Janina, I just wanted to touch on a couple of the takeaway messages from this particular study. And we do hope that this, and along with other studies, will help to raise awareness amongst clinicians and healthcare professionals about the overlap between anorexia and autism, and also to be able to kind of recognise those barriers that autistic individuals face, particularly when accessing these eating disorder services, so that they can make these adjustments and better accommodate their autistic service users. And we also hope that it might lead to kind of further research into specific recommendations for adaptations to treatment and service environments to better suit the needs of autistic people. So I'm going to hand over to Janina, and she's going to talk more about that second aim that I spoke about as well. I'm going to stop sharing my screen.
And I will start sharing my screen now. Yes, that seems to have worked. Hello, everyone. As Bethan said at the beginning, I'm a PhD student at UCL, and I work together with Charli on the SEDAF project. So I will now be talking about the second half of the qualitative study that Charli has just introduced, where we talk to autistic women with anorexia, parents and healthcare professionals about autistic women's experience in eating disorder services. So that's the part that Charli has just covered. And we also asked them about their views on potential causing and maintaining factors of anorexia in autistic women. And then we used the insight from that analysis to develop a theoretical model of autism-specific mechanisms for restrictive eating difficulties in autistic individuals. So I will now be focusing for the next 15 minutes or so on these two aspects. This is an overview of the themes from our analysis focused on the potential causing and maintaining factors of anorexia in autistic women. So according to our participants, their views were that anorexia in autistic women seems to relate to social difficulties, sensory sensitivities, their sense of self and identity, difficulties with emotions, a need for for control and predictability, and also certain thinking styles. I won't have time to go through each of them in detail, but I will just talk about a couple of them to give you some idea about what these themes cover, and also to share some quotes with you. So starting off with sensory sensitivities, as most of you will be aware, sensory sensitivities are very common among autistic individuals. Some say they're almost universal. And when you think about it, eating is a very sensory activity. So it might be unsurprising that almost all of the women in our sample talked about food-specific sensory sensitivities. So the most common one was actually to do with the texture of specific foods, but also taste, the smell of different foods, the mixing of foods, even things like the temperature they were very sensitive to. So restricting their food intake and avoiding certain foods in part was quite a logical way for them to manage these food sensitivities. So I've got a quote here illustrating that. One of our participants said, "I've never eaten a tomato in my life because it's hard and it's squishy in the middle. It just disgusts me. There's absolutely no way I could eat it. And I'm not keen on lettuce either. The fact that it's all mixed up, which in my head shouldn't be mixed up. So for me, salad is actually a terrifying food." And we thought this quote was particularly interesting because you would expect someone with in the numbers on the weighing scales. And I think importantly, rather than that being a means of controlling their food intake, these activities were enjoyable and important to them in and of themselves. So this participant said, sometimes I wanted to lose weight because of that, because I wanted it to be a specific number, because of that number fitting into a pattern or something. So these interests, as I already said, seem to be an important source of enjoyment for these women and were a way for them to cope with anxiety and introduce calmness into their life, which seems to have contributed to the persistence of their eating disorder, made it so difficult for them to overcome their eating disorder, even though they knew that these behaviors weren't good for them. Right, so next I'm going to introduce the theoretical model of autism-specific mechanisms for restrictive eating difficulties that I already mentioned. Bear with me as I do it. There's quite a lot, but it will build up on the slides and hopefully it will make sense at the end. And also notice how I'm now talking about restrictive eating difficulties rather than specific eating disorders here. So we think, based from our data, that there are lots of autism-related difficulties that autistic individuals who might develop an eating disorder might experience in their life. And these are listed here in green. And we propose that these might give rise to restrictive eating behaviors via a direct and an indirect pathway. So in the direct pathway, some of these autism-related difficulties contribute directly to restrictive eating behaviors. For example, as I mentioned, sensory sensitivities to certain characteristics of food could lead directly to avoiding or restricting food intake. Interoceptive difficulties, so ability to sense hunger and know how much and when to eat, might lead directly to missing meals and restricting eating behaviors in that way. And also, as I mentioned, the special interests related to eating disorder behaviors. And then in the indirect pathway, these autism-related difficulties are proposed to result in a number of negative emotional consequences. So these are listed in the blue box here. So they can result in anxiety and mental health difficulties more generally, and they impact on the person's sense of self, and also contribute to the individual maybe experiencing the world as overwhelming and the perceived loss of control. And it seems that restrictive eating can then be used as an attempt to cope with these difficult emotions. Importantly, there seem to be external factors and circumstances that exaggerate either the existing difficulties and or make the emotional consequences worse. So these are listed as moderating factors here. So these include bullying and being misunderstood and mistreated because their autism isn't recognized, stressful life events that these women might experience, and developmental aspects such as puberty. So these are the two pathways by which autism-related difficulties are proposed to give rise to restrictive eating behaviors. And we further hypothesize that these restrictive eating behaviors are maintained because the outcome of these behaviors is that they reduce the individual's initial difficulties and the negative emotional consequences. And from our data, we think that that might happen in two specific ways. So firstly, by numbing down or resolving some of the sensory and emotional experience. So by basically restricting the eating, these difficulties just don't come through as much anymore. And secondly, by introducing calmness through giving a sense of control and predictability. So that's kind of a counteraction that helps these women or these individuals feel better. But at the same time, we think what might be happening is that the eating disorder, once a full eating disorder develops and the effect of starvation also reinforce some of the initial difficulties that the individual is experiencing. For example, cognitive rigidity, or it might introduce further difficulties in their social relationships. So that then also contributes to the maintenance of the eating disorder as well. Right, with this model, there are a few things that I just wanted to point out and mention. One is that this is a theoretical model based on qualitative research, and this research specifically focused on autistic women with anorexia. So as it stands, we can only speculate how relevant different elements of the model are for other women with anorexia. Some of them might be quite autism specific, but some of them might also play a role for other women who develop anorexia. And similarly, we don't know how specific this model is to anorexia or restrictive eating disorders, and how much it applies to other mental health difficulties that autistic individuals might experience. So some of the elements seem quite specific to food and eating, such as the sensory sensitivities that I've mentioned a few times now, whereas others, for example, difficulties with regulating emotions, might contribute to other mental health difficulties as well. So there's definitely some more work that needs to be take place to explore some of those nuances, and more research is needed. And Charli and I are actually currently working on the analysis of a larger scale quantitative study where we looked at some of the proposed elements of this model in a larger, more diverse sample. But we hope that this model as it stands sort of can be an initial starting point for research to pick up and test some of these elements further, and it can also be used potentially in clinical settings to start a discussion and think about whether some of these things might play a role for autistic women with eating difficulties. And to finish off, Charli already mentioned some of these, but this is sort of putting our research into context a little bit. So we hope that our research, together with other research that is being done and has been done, raises awareness and helps eating disorder services to become more autism friendly. And it can also inform the development and testing of new autism-informed treatments for restrictive eating difficulties, and hopefully in the long term can also inform interventions to prevent the development of restrictive eating disorders in autistic individuals. I've got the two papers here that resulted from the study that Charli and I talked about today. As Charli already mentioned, these are open access, so you should be able to read them. And I believe we will put the links to them into the chat, so you can access them if you would want to find out more about this research. And we've also written a lay summary for one of them, which is available on our blog. That brings me to the end of my part of the talk, just to say thank you to the rest of the SEDAF team who've contributed to this work, and of course the participants who have so generously given their time and shared their views and experiences with us. Without them, this research absolutely wouldn't have been possible. Right, I'm going to stop sharing my screen.
Brilliant, thank you both. You managed to finish dead on time, which is really impressive.
Very good.
So our next speaker is Josefina, hopefully I'm saying that right, who is a youth patron, a former youth patron at Ambitious About Autism with vast lived experience around this area. Josefina, I'll let you introduce you and take it away.
Hi, My name's Josefina. I am currently a patient representative at the Royal College of Psychiatrists, and I'm a member of the Insight group at Autistica. I am going to start a master's in York in medical history and humanities, and some of my favourite things are Jojo's Bizarre Adventure, my own cats, giving unsolicited skincare advice, perfume, lots of things, but certainly not food and numbers. I hate all of that. So some context, I first developed anorexia when I was 13. I had some mental health problems before then that went kind of largely untouched by other people. And then I kind of went in remission by about age 15 or so, because my parents implemented what I learned was the Maudsley method, which is basically looking at me like hawks until I finished eating. And then throughout university, I relapsed at several points. I can't really say what exactly made me relapse, but there were loads of relapses. I'm just going to tie in what I'm going to say with both their presentations. So with regard to Charli's presentation, I did find it really hard to reconcile, what does it say here? Oh, no, sorry. Oh my God, I'm so nervous. I'm so sorry. I'm so sorry. So yeah, I did benefit from less traditional interventions. At the moment, I'm doing psychodynamics / kind of humanistic therapy, I think it's called, which looks at the past rather than the present and future. So what CBTE does, which was invented in Oxford, which is where I live, very unfortunate, is that it kind of gives you strategies to cope with the present and future, whereas the psychodynamic stuff, it helps you look into the past and what kind of made you the person that you are now, and how that can help you kind of build a healthier, happier future, I guess. I am now 26, so I've spent half my life with anorexia. I do have some uniquely autistic needs, such as keeping the noise down, having a kind of odorless environment, which I definitely did not encounter in treatment. I was at Cotswold House in Oxford for a couple of months as a day patient, hated every single second of it. So some of the themes that Charli touched on were misunderstanding autism. I wasn't diagnosed early enough, and my behavior, my whole being was misunderstood by my psychiatrist at the time. She would say, "Oh, you're too empathetic to be autistic," or she would associate my my special interest or my mannerisms to simply idiosyncrasies that made me kind of unique and special, but they were autism, surprise. And I think having been, like, if I had been diagnosed earlier, I would have definitely not relapsed as an adult, and I would have led a much happier life, because essentially what drove the eating disorder, what part of what drove the eating disorder was that I felt really different, but more on that later. As I was saying in the chat, CBTE, which is a usual therapy model for anorexic people, it felt a bit like ABA, which is called, that's applied behavioral analysis. It's a very controversial therapy for mostly autistic children, which is based on conversion therapy. And the reason why it felt like that was that I felt like I was being wired into someone that I'm not. And it denied a lot of my sensory needs, a lot of my sensory discomfort. For example, a lot of therapists will say fat is not a feeling, which is true. Fat is definitely not a feeling, that's fat phobic. But as Janina said earlier, there are interoceptive issues that have to do with, for example, I felt really heavy because I digest food really slowly. And a CBTE therapist are usually not trained to detect that kind of thing. what else? Again, treatment facilities are not really accessible for autistic people. We all have very different needs, but there are things that they can do that suit pretty much every autistic person that they'll see. At my treatment facility, 1 out of 5 patients who are autistic, we all counted them. We all got together and counted them. And some things that would have helped me would have been a quiet room specifically for myself, because there was a quiet room, but it was often used by other patients, or it was used to kind of for therapy sessions, or even worse, for like feeding a patient that was refusing to eat. So I definitely could not use the room at the same time. I was also not allowed to wear headphones at meals, which actually led to me having a huge meltdown and leaving the patient treatment pretty much forever. So basically they wouldn't let me wear headphones to meals, and I insisted, and they saw it as a privilege rather than an access need. And they even tried to kind of bribe me with saying, you're not gonna be allowed to wear headphones, but you can leave for dinner earlier, you can have meal at home, which was part of the treatment plan anyway. And eventually I did manage to put on my headphones for meals, but before that there was an incident with two HCAs in which they were laughing really, really loudly, and I stood up. I was furious. I could hear the clanking of the cutlery, the radio, other people talking, and I stood up and I said, would you shut the F up? I was really, really, really that overwhelmed, and nobody had any awareness of what my meltdowns were like. They just thought I was being rude. I've been told that I have really complex needs. They kind of dismissed me as someone who had really complex needs. My therapist at the time, she kind of gave up on me because she thought that her training was not enough to help me. And the psychiatrist that I was seeing at the time at Cotswold House, he didn't medicate me according to what my actual needs were. He neglected the fact that I have other kinds of mental illnesses. I have OCD, I have complex trauma, and he would say that certain side effects were anecdotal. Like I would have really horrific nightmares, and he would say, oh, that's just anecdotal. As long as you're eating, that's fine. Group therapy doesn't work for me, like Charli said, because like, first of all, I don't really care what other people are talking about. If I'm going to have an hour I might as well have it to myself. But also, I get overwhelmed by the sight of other people, by the smells of other people, by the voices of other people, by having to kind of make eye contact because it's polite. And I think OT would have really worked for me. But the thing is, the OT at the hospital, she would teach me how to make a sandwich. Like, I know how to make a sandwich. What I need help with is finding a job. What I need help with is kind of moving through society as an adult. That's part of the reason why I had an eating disorder at age 24. And they neglected so many needs that originated or kind of made my eating disorder keep going. Because they thought of it as a purely kind of food-related issue, despite the fact that a lot of people like to say food is not the issue. If you think food is not the issue, then show it. Sorry, I'm a bit frazzled. With CBT, a lot of behaviors are kind of thought of as problematic, when actually they're just autistic behaviors. Like, I think someone mentioned walking on tiptoes, or maybe listening to music, or having obsessive interests. A lot of that is seen as problematic, and so it's something to be cured or kind of unwired from your brain rather than something that makes you autistic. And I have some notes from Janina's presentation. A lot of you were interested in the interoceptive aspect and the sensory aspect. I'm not sure if this is the same thing, but there are fruits that scare me a bit more just because of the texture or the intensity of the flavor. So for example, you know, there's like awful like 300 calorie ice creams. They might be awful and not very caloric, but they scared me because they tasted really strong. Whereas something that's quite a lot higher in calories, but not as flavorsome, I would prefer to have that. And textures that might be, I mean, foods that might be seen as kind of healthy, I actually hated at the time. For example, I hate cucumber. I absolutely detest cucumber. Whereas a lot of autistic neurotypical people might like cucumber because it's low in calories. Like, I would rather eat 10,000 calories a day than have cucumber. And there were lots of foods at the hospital that I didn't like, but you were only allowed 3 dislikes. It was a big thing. And I felt like I was being discriminated against because there were foods that I had to eat despite them being torturous for me as an autistic person. But because they thought of food dislikes as a kind of anorexic thing, like, oh, I just want to avoid food because I don't like the calories in this particular food item. They didn't let me have more than 3 dislikes. And really it was more torturous than it had to be. Like, obviously I struggled with eating in front of other people, but because of the textures, it felt even worse. And at the moment, in terms of food sensory stimuli, I'm really struggling with cooking because I live in a studio flat, and so the kitchen is kind of right next to my bed, and I hate smells. I absolutely hate smells of food. And so I struggle to make myself cook because I hate that, and obviously that has an impact on my weight. And so I find myself eating, say, toast or anything that's odorless, as long, even if it's more caloric, but as long as it's odorless, I would much prefer having that. With regard to interoception, a big thing for me has been, again, like I mentioned, dealing with gastroparesis as a side effect of not exactly the eating disorder itself, but Ehlers-Danlos syndrome. So Ehlers-Danlos syndrome is a connective tissue disorder that happens to be very common among autistic people. And gastroparesis is a side effect and illness on its own where your digestion is very slow, and sometimes it doesn't even happen. For me, thankfully, it's mild, but it worsened because I abused laxatives at the time. But at the hospital, they thought, oh, you've just got to push through it, and we'll give you some peppermint sweets to deal with the wind. But, you know, what are peppermint sweets going to do for me? Absolutely nothing. And this whole mentality that I just had to push through it neglected the fact that I had a genuine health issue. And my eating improved, not dramatically, but kind of definitely without going back when I started taking prucalopride, which is a medication to deal with gastroparesis. Because it made me realize that fullness was not permanent, and I could go to the bathroom a lot more easily, and I didn't have to deal with that horrible feeling of kind of having a weird perception of myself just because I felt full. It feels very all-encompassing, and so it gives me the impression that I'm wider than I actually am, even if I think I look relatively thin. And I think this is widely neglected in eating disorder services. There's also a very notorious neglect of comorbid conditions that are not mental health related. If my Ehlers-Danlos had been considered, much of my distress would have been avoided. So with regard to self-identity and difficulty with emotions, when I was, is everything okay, Bethan? Because you've set your...
I'm just going to have to cut you off in about a minute's time. Just giving you a minute warning, I'm afraid.
I'm so sorry, I didn't know how long the presentations had to be. just going to touch really quickly on that because a lot of people were interested. So when I was younger, I thought that I could communicate how I felt through my body, kind of non-verbally, because I had a very sophisticated mindset, I guess. Like I thought people would understand what I meant by starving myself. But that obviously didn't work. Now I find it hard to let go of the anorexia because when all else fails, when I'm not a good scholar, academics, or good autistic advocate, when I'm not a good anything, what I think I can be instead of that is a good anorexic. I'm really struggling to let go of that part of my identity. And in terms of thinking styles, I once had a meltdown at the psychiatrist that I'm seeing now because I reached a number that in my mind was forbidden. I honestly don't care for numbers in general, or exercise or weight. But I couldn't imagine being beyond that weight range. I also struggle with the idea that the number in kilograms must be equally as pleasant as the number in pounds, but I don't know anything about stones, so that's fine. And lastly, intolerance of uncertainty. One of the consistencies of my anorexia has been that it reflects my fear of the future. When I was unaware of my autism, I was worried about the future beyond school, having to be like a boring grown-up and having to like not being allowed to like certain things, like more childlike things. My best memories were all from like primary school, and I didn't want to let go of that. And then once I graduated uni, I was left without the support system that I had. I was worried about the future, desperate about the failing job search, and increasingly mad at my therapist. And so at least what I could have was eating disorder. One very, very, very last thing, what is helping me now, which I think could be of use to many of you, is psychodynamic therapy, like I said, and not discussing food. Food is a secondary thing. What I need to talk about is my self-esteem issues, my painful memories, my trauma, things that are making me feel depressed and scared now, not the food, because that has a repercussion on what I eat. And also not knowing my weight. My psychiatrist said, I'm not putting you through that ever again. Like, even if I'm emaciated, he will not weigh me, because he'll be able to tell the signs of extreme malnutrition, but I'm not being weighed at all. And that has had a significant improvement in how much I eat. And well, given the time, I think that's it. Feel free to ask me anything. I'm not easily triggered.
There you go, I'm muting myself. Thank you so much, and really sorry to cut you off. I think I could definitely have listened to you speak for a lot longer, and I'm looking at the comments in the chat. We're definitely not the only one, both here and on Facebook. They've been massively positive.
Oh,
How great it was. So yeah. Janina and Charli, if you want to join us again, we'll go do a couple of questions. Yep, chat is just going. Josephine, you've done brilliantly.
Lots of positive feedback for you. That was that was brilliant, Josefina.
thank you.
Definitely. So you've addressed some of the questions already. I think we'll start with quite a simple one, but one we definitely hear a lot, which is why women and girls? Why, kind of more than anyone else, is it women and girls who end up getting anorexia or have anorexia? So I'm just going to put that out there. Yeah, you can choose who speaks first. Sorry.
For that one, or
yeah, I can start. We have this question a lot. Why are you kind of focusing on autistic women, not autistic men, non-binary people? There's a few reasons, I guess. Like, I mean, yeah. So, I mean, within the literature, the research, it tends to be focused on women. I guess, you know, one of the reasons why we have it's kind of a time-constrained project anyway, which kind of limits us to an extent. And in kind of services, eating disorder services, you find that there is an overrepresentation of women with anorexia. So just in terms of kind of practicalities as well, it would be quite difficult to recruit enough men to and non-binary people to kind of be able to produce, I guess, sufficient research in that area. But we do hope that kind of the stuff we are doing, you know, might be able to inform future research that looks at kind of other genders. And that's something that we really hope that we can be taken from our research. It's quite interesting how there's kind of this, you know, overrepresentation of women in anorexia, but also this underrepresentation of women in autistic people that we see. And that's another reason that there seems to be this kind of female phenotype of autism, where autism might kind of present slightly differently in girls and women than you kind of see in the kind of more typical male presentation. So we're quite aware of that and how that might affect males and females differently. So that's just a kind of few reasons why we kind of decided to focus on women for this project. I don't know, do you have anything to add, Janina?
No, I think you answered that very well. Just to emphasize that that doesn't mean that it doesn't exist in men and people who identify with other genders. Absolutely, and we hope that some of this research really is just a start, and that we can explore that more, how eating difficulties affect other populations. In general, Charli mentioned that there is sort of an overrepresentation, regardless of sort of in the general population, of women having eating disorders, in particular anorexia. But we also know that men are often under-recognized. In part, it might be though because women are socialized in a way to focus more on their weight and shape, and women in general tend to have more internalizing mental health difficulties, and eating disorders are one of them. So there could be all sorts of genetic reasons for that, societal reasons, but also an important fact is that men are often missed.
Brilliant. Thank you, guys. So we've had a lot of questions in about interoception, particularly after your part, Josefina. So one question is kind of around recognizing the sensation of hunger. And another question is kind of just internal body sensations generally. Are they more intensely felt, or is it different feeling? Josephine, do you want to talk about your kind of experience first, and then we'll move on to Charli?
Yeah. So not so much now, but even a couple of months back, I used to feel like hunger made me feel like I was on the right track or something like that. It gave me certainty. It just made me feel like I was doing things right. Whereas when I was full, even now when I'm full, it's like I'm entering crisis state. There's uncertainty and not knowing when that fullness is going to be over. Because like I said, I process food really slowly, and I worry that I'm going to look like that forever, even though I know that I'm not going to be bloated forever. But there's a really, now that I look at it, there's like a kind of dichotomy between certainty and hunger, and uncertainty and fullness. That's what they represent for me. And other bodily sensations that I feel very intensely are sweat. I hate the feeling of sweat. What else? Anything on my hair, like if it feels really greasy, or any texture that is different. Like for example, I've just washed my hair and I think it feels very different to the usual because it's still drying. Periods, that's a really, really big thing. So I've got kind of dysmenorrhea, which is like shitty period, not no period, but like a really bad period. I only get it for about 1 or 2 days, and I hate the feeling of periods. And that can often be a big reason why anorexic, autistic people may not want to get better, or might fear getting better, because what if their periods return and they feel absolutely disgusting? It's a big thing for me.
Brilliant, thank you for that insight. Charli, Janina, do you have anything to add? And just to add another question which come through about interoception is just around kind of, do you build in any tools about increasing interoception in the work you've been doing? Is that kind of a feature of it, or I guess increasing awareness of the body?
Really interesting. Sorry, did you want to say something there?
No, I was just confused.
Really interesting. I will pick up on a few things and I hope I don't miss anything. What Josefina said about periods reminds me of one of our participants talking about puberty and how that played into the eating disorder because of the changes her body was going through, and just that change feeling very uncomfortable for her rather than the body image as such. With interoception, I did cut that a little short in my talk, and there's more information in it in the paper, but it was really interesting. In our sample, it was sort of going both sides. Some participants who were affected by this reported sort of hypersensitivity and the others hyposensitivity. So either being very sensitive to internal sensations and sort of just the digestion of food, being actually quite comfortable and not eating to uncomfortable and not eating to avoid that. And then other participants said that they couldn't feel very well when they were hungry and how much they should be eating, and that could either lead to them missing meals very easily or eating a lot of food and then feeling guilty or uncomfortable afterwards and then restricting as a result of that. So it was sort of going in different directions, and it's important to keep in mind that this was qualitative research, so we don't really have a representative overview of this yet. But we know that in general, autistic people often have difficulties with interoception, and that then also links into things like feeling pain, so not necessarily only specific to eating, but it would make sense that it plays out with regards to food and eating. And then the other question I think you just asked was about how that could be incorporated sort of in a treatment context. Charli and I aren't actually doing any work in that. We're sort of doing the research side, and I think the research isn't quite there yet, that there are specific treatments to address that, but I know of some very exciting research looking at using interoceptive signals to help people to draw attention to their body. And I think this is Sarah Garfinkel's research, and she has included, she has also looked at this in autistic people, basically to train people to be more in tune with their body with the help of initially using external clues. So I know that there's some research out there and that there are things happening, but this is still in early stages.
Brilliant, thank you. Charli, do you have anything to add?
No, I think Janina's covered it all.
Sorry, just one more thing that I remembered about interoception is that I hate the feeling of my own skin touching itself. And so when I sit down and I feel, for example, bits of my stomach touching itself, if I bend kind of like this, I hate it. And when I was younger, I used to interpret that as being fat. Or when my thighs are up, or like if I'm walking and I feel my thighs, even though that's perfectly normal. When I sit down, especially in the summer, and I can feel different bits of my skin, there's nothing that I'm not feeling at the moment, and that can make me think I may look wider than I actually am. And it's such a distressing sensation, and that alone can drive the urgency to restrict. I'm really struggling with that.
Brilliant. I mean, not brilliant for you, obviously, but it's really fascinating to hear kind of the actual insight behind one person's experience in detail. So I
guess it's hard for some people to tell the difference between feeling fat and having interoceptive differences, and I think it's worth knowing how to detect autistic people, autistic women in treatment settings, in order to teach them about interoception and maybe decipher where things are actually going. Is it what you think is a feeling, or do you actually have interoceptive difficulties with understanding your own body? Yeah.
Brilliant. It sounds like quite a journey going from realizing you're autistic to kind of picking out these individual elements of it.
I could have avoided all of that if I had only been taught that I was autistic when I was 13, and so I've spent half of my life not knowing what I am. Part of why I developed anorexia was also because I felt very different from the rest of the world, or rather than people were different from me. and that I was some kind of anomaly, like something that shouldn't exist. And it was so distressing, feeling like I was a wrongly misplaced alien in the world. I very much related to The Little Prince by Antoine de Saint-Exupéry, where you've got this little boy that has dropped on the face of the earth and finds an aviator, and he makes questions about life on Earth. And before that, he met different people on different planets, and they all seemed so shallow, so different, so cruel. And he misunderstands a lot of the relationships on Earth, a lot of the social rules. And I felt exactly like that.
Thank you. It's good.
Thanks for sharing that. That sounds really difficult, but so valuable to hear your insights.
Definitely. And yeah, I think us chat shows definitely not alone in that. Everyone's really enjoyed listening to you tonight, and the same obviously for you and Janina and Charli too. It's been fantastic having you all here with us.